And then from here, we're going to turn it over and transition a little bit early today. We're ahead of schedule, but we're going to go ahead and kick it over to our first panel of the day, which is going to be holistic care models for people who use drugs. And I'll let our two panel members introduce themselves.
Hi, my name is Cole Meckle, and I am the founder and executive director and lead pastor of Gather Church and Gather Community Services in Centralia, Washington, lovely Lewis County. And we provide, among other services, we have a Health Hub Light model that we operate with currently, low barrier mood, offering behavioral health care services, some hopefully scaling as we move along, primary care services, a lot of case management. In addition to those services, we also operate a recovery cafe. We do a lot with housing and employment services, addressing food security, do a lot with early childhood learning and parenting education. Yeah, it's really great to be here and participate in this again this year. So, Everett, do you want to introduce yourself now, or are we doing that late? Are you doing that later?
I'll go ahead and introduce myself. It's fine. That's what Katie asked me to do.
All right.
I'm Everett Maroon. I'm the executive director of Blue Mountain Heart to Heart and Walla Walla. We have offices in Benton County, Walla Walla County, and Asotin County out in Southeast Washington State. We've been around since 1985. We started as an HIV case management organization with 16 local Walla Wallans founding the group. And I'll talk a little bit about that when I get to my slide deck. At this point, we in 2013, we added to our mission care for people with substance use disorder. And so we've done a variety of harm reduction services since the late 90s. Including syringe service programming. We've got a variety of services, just like Cole talked about with his team, his organization. So everything from harm reduction, wound care, distributing naloxone and training people how to respond to overdose events. I think we're well above, we're into several thousand reversals since we started that program in 2014. We have a clinical program where we administer low barrier buprenorphine to people. We also run medical and mental health services at the Walla Walla County Jail and the Juvenile Justice Center. So there's a lot of continuum of care and continuum of service that we focus on out here. We have a lot of collaborative partnerships with community paramedics, our emergency department at the hospital, our Action Council organization, housing authority, to try and create a very thorough wraparound care service for our clients. We have two different diversion programs that we operate here in a braided format between the Washington Association of Sheriffs and Police Chiefs and also the Recovery Navigator program. We were awarded the rural pilot site for health engagement hubs, and I'm extremely happy to hear that HCA is going to award 3 more pilot sites, and that will be that opportunity, I think, is out now. We're about to come out, so everybody should take a look at that. But really happy to see you all today and get to talk about our work, and I'm sure Cole and I will be around even after Q&A for folks who want to get in touch with us later with questions.
Yeah. All right. So I'm kicking off the first part of this, and I just wanted to say a few things leading up to this. So I personally appreciate everyone taking part in this event, and y'all are involved in very challenging work, very life-giving work, but also very challenging work. And in my life, in the last, I don't know, 15 years, I have in the harm reduction field of work, met some of just the absolutely most amazing people I would ever want to meet. And I'm sure every one of you, if not, even if I haven't met you, are amazing people. But so many of you are part of this meeting and part of this training. And so I'm just staggered by the level of compassion and love and care that you all offer in your communities. And so so thank you. I just want to honor you in your efforts and your hard work. It again is so meaningful and so life-giving, but so challenging all at the same time. So as I move forward here, I do want to say that I want to address some of the struggles that we face in our healthcare system that we are trying to overcome with health hubs, but I want to say that I want to be understanding that that our systems are broken, and that I'm not trying to suggest that there's some nefarious intent in any of this or anything. We just have systems that haven't been built very well for a lot of different reasons, and so but I want to be realistic about some of the struggles that are faced. And so I don't want to shy away from just how some of these systems negatively impact individuals. So with that said, if you can see the images on your screen, hopefully, this is how our healthcare systems feel to some people. They have some serious accessibility issues. So it's like, there's no stairs to the entrance to the second story of the brick building there, and you can't get on the balcony of the other building. It's like some pretty major construction problems there and systems problems. And that's what it oftentimes feels like to people that are trying to gain access to some support, whether that be substance use disorder support, whether that be behavioral health support, medical care support, just somebody to talk with, somebody to support them. It's just very, very challenging system and systems that we face. And what I've discovered, as many of you probably have as yourselves, is that people wanting to pursue some kind of connection, some kind of help, some kind of community, some support, let alone actual behavioral health care or substance use disorder treatment, is extremely difficult. And there's so many barriers, and want itself isn't enough. As a matter of fact, sometimes what we find is people want some support and encouragement, and constantly trying to find it becomes a discouragement because they can't find any place to connect. Lewis County, we started Lewis County's first syringe exchange, I don't know, what was that, 3 years ago now, 4 years ago? 4 years ago, I think. And it was the first syringe exchange to ever exist in Lewis County. So you could have wanted to gain access to harm reduction supplies in Lewis County, but it was impossible to find it because there was not anyone doing the work. And believe me, many of you know this already, it is super challenging to do it here in this community still. But for the sake of those who are seeking those points of connection and that access to healthcare, we continue to forge ahead. So it seems, though, moving back just a little, and if I go to the next slide, it seems like the higher people's acuity, the harder it is for folks to access services. So I hope this makes sense to you. I'll try and explain it a little bit here if it doesn't. So it's like the bigger the struggle people have, the harder it is for them to find access to, say, for example, just behavioral healthcare services, especially if folks are dealing with super complex needs. Next slide again, please. So it's as if those with the greatest need face systems that seem like, and this is how, I'm not saying it really is this way, but this, I don't know, it feels this way to people that are trying to gain access to care. It seems like it's intended to keep them out. And, there are a lot of reasons our systems are built this way. Sometimes it's a matter of the fiscal model of, if you are not having a client before you, you're not going to be compensated for the work you're done as an agency. And so for fiscal reasons, people have to try and account for making sure people are going to make it, which means they're not going to schedule higher acuity individuals in their office visits. And so, but again, like, it is desperate making and frustrating for individuals that are trying to figure out how to find some help. So I'm hopeful these QR codes are working. If they don't, I will send, yeah, I'm really sorry. I will send out all of these links and get them into the chat a little bit later today. I have no idea why they're not working. They were working day before yesterday. So I'm very sorry about that, but I'll take care of those things along the way here as I can. So this QR code is supposed to bring you to an article from the National Academy of Medicine addressing 9 key barriers that prevent access to evidence-based care. Some of those barriers include things like stigma, inadequate clinical training, a dearth of addiction specialists, lack of integration of medication for opioid use disorder provisions and practices, regulatory and statutory. Some of these things have been addressed a bit in our country over the last couple of years, but they're still withstanding. So, and issues around data sharing restrictions and some of the things I already mentioned, like financial barriers. There are a lot of complex reasons that people are struggling to gain access to the care that they need that makes it feel like, that people just don't care and people just don't want the help. That's what it feels like to people on the other side, right? So I want to share a story, and I've changed the names and details in some regard to, for obvious reasons. So this is going back 10 years ago. And there was a young person that used to sit outside of our cafe every morning and wait for us to open up, and would come in, and they were struggling with co-occurring disorder, we discovered along the way. And so we were trying to help this person receive some behavioral health care services. And for what it's worth, they were this lovely, wonderful individual who had been a law student, had become pregnant, had some behavioral health struggles during pregnancy, and her life just really spiraled out of control. And so we would pick her up and bring her, literally, but we would pick her up to bring her to the only behavioral health agency that existed in our county at the time, and would bring her for drop-in assessment opportunity. And it was basically sitting in a room and waiting for an opportunity for this individual to maybe see a counselor and maybe be assessed and get into some supportive services. And numerous time after time, I think we went 4 or 5 times and were never seen. It was so frustrating. It was so disappointing. Same situation with their substance use disorder. It was really frustrating. It was really disappointing. It was at that point when we realized that there were some needs we needed to address in the community, not just in trying to gain access, but expand the access to some of these services. And so we got involved with helping other behavioral health agencies move into our community, and then have scaled things ourselves from that point. But there are an estimated 8.9 million adults in the United States that have co-occurring disorder that need integrated treatment models and supportive care services. And it's just so hard and so disappointing. And we need to figure out how to help these individuals that have high acuity. It is like when people just start taking one step in the right direction or in a direction of hope, and people feel like doors are just shut in their face. It's not just a matter of trying to get started and not gaining access that way, but because of oftentimes a lack of understanding of the issues that people face and the struggles people face, and ongoing stigma. People that are maybe on a path to addressing and finding some care hit obstacles along the way, like the picture here. Can you imagine riding upon that at 15 to, 25 miles an hour and hitting that post? That's what it feels like to people. So another story real quick. Young man named Dylan. This was before we had our SUD program up and running and our MAT program up and running. There was a MAT provider that started in town that was quasi low barrier, but basically the model was you got to sit down, talk with somebody in a lobby for a moment, typically a receptionist, and then see a primary care doctor, an MD prescriber at a telehealth visit. That would be a different person every time you sat and talked with them. that oftentimes was not very well trained in understanding the complexities of substance use disorder and mood treatment. And it would be variable because you would, again, not see the same person every single time. This particular individual, Dylan, he was living in a facility that was low barrier access to housing. And the provider that was talking with him was so stigmatizing and so judgmental, and basically telling him the place he was living wasn't a good enough place to live and he needed to go find a better place to live, and was trying to encourage him to just leave where he was at, despite the place being quite safe. It was just that he might encounter somebody else who uses drugs along the way throughout his day, as if that weren't going to be the case in other aspects of housing opportunity that, well, didn't exist anyway. But he just felt just judged and mistreated and abused and desperate when he walked out of there. And so, again, we just need systems that are better at caring for people, that don't stigmatize people. We hear this, and you probably do in your communities as well, where people that are on medication for opioid use disorder are just are really stigmatized, even as they're on treatment and as their lives stabilize. They're still continuing to be treated judgmentally and taught, and like this happened in our community recently at a fairly large event where an individual in the community in some position of prominence was suggesting verbally to someone that they were, because they were on buprenorphine treatment, they were just trading one drug for another. And it despite the strength of the individual that was told that, they were devastated, they were hurt. It's we need to continue to transform our communities, as we're seeking to do here today, right? So, okay, next slide, please. So just a little bit about Health Hub models, and I'm so excited Everett is going to talk even more about a lot of these things, but this is just a little bit of the difference between more traditional understandings of how behavioral health care and SUD treatment services are offered and the experiences that people have versus a Health Hub model using a supportive low barrier model. So, and I know there's variation on all these things. So in our community, generally, even today, if individuals are in behavioral health care or SUD or primary care services, they're discharged after they miss 2 to 4 appointments. And we're working with an unlimited number of opportunities for people to return. We work from this standpoint of accountability without termination. We continue to try and encourage people to come receive whatever care that they would like to receive. Connection, community, and continued support and encouragement. Traditional in our community, there's some really extended wait times for folks. We have most oftentimes, same day opportunity to see a provider, to see a care navigator, to see a nurse. We offer drop-ins for follow-ups. This is most often not the case in a more traditional setting. There's little to no support between appointments. This is variable, but we offer a tremendous amount of support between visits, reaching out, making phone calls, trying to connect with people one-on-one, offering different levels of support groups, very wrapped around service from care navigation to nurse to a provider contact. We really offer a lot of support. Again, I understand, and I'm not trying to discourage other models of care. It's better to offer services in a community than not, but oftentimes seeing a receptionist and a provider on a telehealth screen is just not enough. We need a lot of support for people. And again, this model of using a care navigator, a nurse, and a provider in that ongoing contact and wraparound services is so essential. Typically, again, to single service in many mood settings. Here, we're working in this Health Hub model to develop really robust wraparound services, mood services, primary care, testing, wound care, counseling, intensive outpatient services, and really working to overcome the stigma that oftentimes comes in settings of care for those who are struggling with substance use disorder, people who use drugs. So, Yeah, we work with people that are struggling with polysubstance use. So we're not going to tell somebody they have to stop using all substances to get started, that's for sure. And there's other issues. We're able to move a little more quickly around things like dosage, and different new medications. We have a lot of our clients that are on Sublocade now, and other agencies in the community, just due to the scope and size of their organizations, have a really hard time adapting new policies to account for new medications. And so here we're way more streamlined and able to integrate new levels of care and new types of care much more quickly. So next slide. I'll go over this last two pretty quickly here. So some of you are familiar with some of these concepts. I think this was talked about last year as well. But we operate from a harm reduction approach. So not just harm reduction programmatically, but harm reduction philosophically. And so this is the approach we encourage all of our team to embrace and to live out. And so a few of these just real quick. Individualism. No two people are exactly the same. When we are caring for people, we have to remember that each person is an individual, and there might be commonalities on some level between people, but individuals are individuals, and we need to recognize that. We need to recognize that we are taking a pragmatic approach. There isn't such thing as perfection. Nobody will ever achieve just like the perfect life or a perfect anything for that matter. We're always working within a spectrum of health and moving in hopefully a positive direction ultimately. So incrementalism is this, and to sum it up, an idea of celebrating every positive movement that somebody makes and recognizing people don't often make huge leaps there. We need to celebrate positive movement, however tiny it might seem. It's really important to encourage people when they have been in situations where they felt so discouraged. Autonomy. Yep, we're working. Nobody likes their autonomy taken away or to be perceived of as having it taken away. We need to work and encourage people through things like motivational interviewing to embrace the direction that they're going to go. Self-determination is key. Helping people set goals and discover what they would like and help them journey in a positive way to meeting their goals, which leads us to the last part, accountability without termination. Such a huge concept in a harm reduction approach. We will encourage people to be reminded of the goals that they set without judgment and without termination. So when we are engaging with individuals, as we get to know them, as they establish goals for themselves, we're just there not to terminate their care, but if they aren't meeting those goals, but just to help them figure out, okay, this is the goal that you set. Do we need to adjust the goal? Is there something that came up along the way that we need to change or to help you overcome because there's a barrier and obstacle in the way to achieving those goals? So very key and hugely important in this model of care. And my last slide. This is a challenging one. And so there's oftentimes such an incongruency in places trying to, and I'm really compassionate to how hard this is as a leader, but there's an incongruency with encouraging a harm reduction philosophy when it comes to how care is being offered, but the incongruency comes with how staff are being led. So workplace culture and care culture. So the way I try and explain this is I'm encouraging our staff to operate in those 6 key principles of a harm reduction approach when it comes to working with their clients. And I need to do that, and other leaders at Gather need to do that when it comes to how we're leading our staff. We can't expect care staff to offer compassionate harm reduction care if they're not led with compassion. And I can't tell you over and over again how many people come to us working in different behavioral health settings or in different scopes of work, and they come with a tremendous amount of workplace trauma and a lot of hurt. And usually it's around a ton of pressure that people have placed on their shoulders to do their job with the threat of termination or the sensed threat of termination. And it's really difficult for individuals to offer compassionate care when they feel that kind of pressure to live up to some expectations of their job. Now, don't get me wrong. It's not like there isn't a job description and there aren't things that a person needs to do. We all have those responsibilities, but that pressure doesn't help. Let me tell you one last story. We interviewed somebody recently that was coming from a different BHA, and they were talking about how they recently were part of a group that were in a competition to see who could see the most clients on their list and have the most people show up for their visits. And they were talking about it not necessarily as a problem. And I was sitting there thinking to myself, like, what ultimately does that kind of expectation or goal, what does it communicate and what does it do long term? And I'm afraid that things like that compel people to start to subtly embrace a potentially judgmental attitude toward clients that aren't going to be as willing to show up because you just entered into this competition trying to see as many of your clients as you possibly could and get them there, and you might be a little upset for the ones that didn't show up. And so those are the kind of tactics that I know places use, but we have to get away from using those things if we're going to offer genuine, supportive, harm reduction focused care for our clients. So that's all I have for you for now. So thank you so much.
Great, thank you. We'll transition over to Everett and then we'll have some conversation.
Hi guys. I'm Everett Maroon. I'm out here in Walla Walla, the executive director of Blue Mountain Heart to Heart. Thank you so much, Cole. Cole and I spend a little bit of time together every month as part of the support that we get from UW for our low barrier buprenorphine programs in our respective areas. So Cole is in a rural area on the west side of the state, and I am in a mixed rural and suburban area in the southeast corner of the state. I think if you hit your space bar, it'll like put another thing on this front slide here with like the date for today or something like that. And we can go to the next slide, please. There just might be, yeah, there's an extra tab. So we were founded in 1985, and I always say to people, this is one of the things I want everyone to think about. The stereotype about rural areas is that they're backwards, they're regressive, they're always behind the curve of the leading edge set by people in urban areas. But 1985 is pretty early in the AIDS crisis. It's not a decade after we were first all starting to worry about what this this new virus in our retrovirus in our midst was. People came together and said, we need to support folks who are in our communities who are facing this grave illness at the time, which was not treatable or manageable. AZT was not on the market at this point. A lot of people from the Tri-Cities came to Walla Walla because they were too terrified to send their loved one or go themselves to their family doctor. And so they came and saw Dr. Dick Simon down here in Walla Walla. And we probably helped more than 250 people die with dignity, which was a really hard time for us. As part of our prevention work around HIV, we got involved in the syringe exchange. I think people even called it needle exchange very commonly back then. And that was just not a hard thing for Walla Wallans to get their minds around. It really wasn't until 20 years later and in the Tri-Cities before we saw any kind of pushback on harm reduction. In 2013, we decided that the work that we had done to serve people with compassion and in our trauma-informed harm reduction oriented way should expand to people with substance use challenges. And I kind of pause over that because millions of Americans use substances every day. in a way that does not include a negative consequence in their lives. So, the people that we're focused on are people who include folks in use and then folks in what we would call disorder, where there's a negative consequence in their life that they are interested in reducing the harm from that behavior, or they're interested in reducing their use, or they're interested in recovery or increased wellness. And we are agnostic to what they are interested in doing. We want to be able to help them at any of those points. So next slide, please. So if when I think about where public funding has been in general around substance use, it's really been about prevention. So a lot of school-based programs trying to keep kids in everything from Just Say No, Nancy Reagan in the 1980s, and we all know how well that worked, to newer curricula that are presented to primary and secondary students all across the country. And then a lot of funding for recovery programs. And that includes recovery housing, treatment, inpatient, residential, outpatient. But for people who are engaged in use, in active use, and somewhere, I know that contemplation is a stage in the stages of change in the trans theoretical model. But for my little graphic here, we're really looking at it as a spectrum, because on Monday they may be very oriented toward contemplating change, and on Thursday, as the weekend is coming, they're really not. We're still going to serve that individual, even if they are kind of going between areas around pre-contemplation, contemplation into action. So we see that this deprioritization of this population of people using substances has meant that they're really underserved, and that they face a lot of stigma because there's no apparatus that's traditionally been set up to think about their needs and treat their needs as something deserving dignity, attention, and investment. So basically public or criminal justice has sort of stepped in here with punitive responses, because that's what criminal justice knows, instead of therapeutic responses. But harm reductionists have been in this space for a long time, since Dave Purchase slapped a card table down on the sidewalk and said, we're going to support ourselves. So there's some more funding coming in now, and there's been a lot of talk around opioid settlements and all that, but this is where we're sort of centering our work. And that's where things like health engagement hubs and our other work are to try and serve people that are traditionally underserved. Next slide. This is a little bit about our organization. Just to sort of show you, this is the staff, pretty recently created, current. We still have our traditional Ryan White program for people with HIV. Of course, there are people with HIV who also have substance use disorder. But that's sort of our starting point. And that's a pretty small number of clients in our catchment. But when we start looking at, opioid response, I guess I'd even call it substance use more generally now, we have many, many more clients there. So you can see the amount of staff that are dedicated to each of these. LEAD stands either for Law Enforcement Assisted Diversion or Let Everyone Advance with Dignity. That's the diversion model that started in Seattle in 2011, and we have two different programs that are diversion-oriented programs there. So there's a lot between, so you can see even in the orientation of the organization that we can do a lot of crossover work between staff, because we do a lot of crossover work between programs. And so then we've got a clinical and harm reduction orientation that I've put together as what we call drug user health equity. Okay, next slide. When we think about how we're serving people, we start off with confidential and anonymous services for folks. So if you don't trust us, you don't know us, you've got a history of being stigmatized by other providers, that's okay. Our door's open and we can start working on that trust relationship. As Cole pointed to earlier, they faced a lot of barriers, and there's a long tail effect. Other survey work that I've done with LGBT people showed that once they had perceived discrimination in a healthcare setting, it could be 20 years later, they were still hesitant to seek further care. That's not entirely different from this population, where they become afraid to tell the doctor about something, even if it's not related to their substance use. But certainly if it is. So they think they have an abscess or something due to, infection at an injection site. They really don't want to bring it up. We acknowledge that trauma history is there, that history of stigmatization is there. And so we start off with like a pretty light, we're not asking for much from people in order to get some things. And then we move into, acute wound care. We need to talk to people a little bit before we just throw, nicotine replacement kits at them. So there's a little bit more of a, kind of background, maybe clinical history just before we can distribute an over-the-counter product to them. If you want to get a vaccine, we now have to look and see, have you had one before? We have to register in state-based systems that you're getting a vaccine. If we're going to do STI testing, we have to collect some data. So that little line there is like, this is where we get to know who you are. We will know your name, we'll know your date of birth and some other information about you. And so we're kind of moving into higher engagement and care. And we're moving into like, we know more information, but we have a deeper professional relationship with you. So once we talk about contingency management, which is an absence-based program around stopping use of psychostimulants like methamphetamine, based on small but increasing incentives, our diversion case management, our individual counseling, which is, I will just make an aside, a super cool program. I thought saying, hey, can I get my counselor to be a field-based counselor? Sort of like I had this like idea in my head. You could like meet them at the bus transfer station and then go to McDonald's and do your counseling session outside at a bench or whatever. But what's really happened is like, she's got someone who can never stop moving. And so they do their therapy session walking around Pioneer Park in Walla Walla, or, she's got someone who has a lot of trouble, with mobility. And so she just goes to their home, and it's been great. But obviously, we need to know a lot more about you, right? And our low barrier buprenorphine program, where we work with several different kinds of bupe, with folks. We really need. You're now a patient. We need to know a lot more about you. But that is that trust relationship gets built, and then we are ready to engage in deeper, more complex care for people. So this is sort of the precursor that led us then into establishing primary care through the Health Engagement Hub. Okay, next slide. This is our no wrong door approach. So again, you're walking in the first day, and we're going to try and it's up to you, the individual, to tell us why you're there, what you're looking for, and then we can tell you where our services overlap with what you're saying you need. And then we can like think about what are all those other services that sort of abet the thing you're asking about. So if you're asking for, a one kind of service, we can say, what do you think about this? Would you also be interested in XYZ? If you're worried about HIV, how about we also test you for hepatitis C and syphilis? How do you feel about that? And they'll say yes or no. And now they can ask us questions and we can have a conversation. So, we bring to bear everything that we can on behalf of the health needs of the person in front of us. That's another way of, establishing trust with them and letting them know that, like, you know, there's lots of things that you could work with us on here, and you don't have to do it all today, this minute. Probably there's somebody idling their car in the parking lot waiting for you to come back out with everything that they wanted you to pick up for them, right? So, you know, but we will tell them about other things that they could get, and that really fosters good conversation, more interest, and they're walking in the door because they are interested in increasing their wellness in some regard, right? They don't want to use the same needle again. They don't want to, you know, their pipe broke and they don't want to use some broken glass, or they are worried about a wound that's festering and they heard that we have a nice nursing staff. You know, whatever it is, something is bringing them in that is an adaptive motivation, internal motivation. So we are trying to capitalize on that with them. Next slide. These models of care look pretty familiar, don't they? These are things we think about in urban areas. They are also entirely all applicable to rural areas as well, although we sometimes need to make some sorts of adjustment. And I appreciate what Cole said about telemedicine earlier. I find that the problem really is the changing, ever-changing provider. You can't establish trust with a brand new person. It's exhausting every single time that you come in, especially if they're stigmatizing to you. But if you really don't have another way, we had a long distance trucker as a client, and it just was really impossible to get him to come in because, you know, that his schedule just really didn't allow it. But he could definitely hole up in his cab and have a telehealth session with our provider, and they got to know each other really well. They did really good work together. He's not even our client anymore because he doesn't need us anymore. So it's great. But you know, all of these models are things that we can leverage in our own environments. Sometimes we have to think a little bit more creatively than others. Next slide. Okay, so this is really, I'm still slightly terrified of this list, but I am really also very excited about it. So everything that's not in italics is work that we're doing right now through our, you know, through that whole big org chart that I showed you. Everything in italics is the proposed new services with the advent of the Health Engagement Hub for our program. So we're bringing on an MD, our first own full-time medical doctor person, which is great. We now have her 1 day a week, and we'll have her full-time starting in September. You would not believe the lead time of notice that doctors need to give their employers. Well, some of you would believe it. We're trying to move to a primary care service for people. Why? Because we know a lot of them have that trauma from traditional providers. B, because we have a lot of patients that we've sort of hit the wall of what we can offer them currently. And I would really like to be able to do more with them than what we can do in our limited facility setup. And C, I continue to see gender disparities in the people that we're serving. So a couple things get in the way for women. One of them is really around pregnancy. And I'm not saying that only women get pregnant, but I'm saying that, you know, for women in especially in abusive relationships, pregnancy becomes a real point of Norco wants me to update my CPAP equipment. For people who get pregnant becomes a point of real potential violence for them, and a lot of pressure to continue substance use in a destructive way because partners are looking for them to do that. We had 6 congenital syphilis cases in Walla Walla County in 2023, and I would really like to see that number be 0. So thinking about full reproductive health care for men and women and for everyone is an important goal, I think, for all of us on staff. We certainly also see this pretty big barrier around you know, the state prying into people's lives when they think that substances are involved, with removing children, in creating uh, a lot of appointments with family court around guardianship of children already born and children gestating, and we want to be able to do more work around supporting people who are maybe not entirely not using substances anymore, but are still pregnant and do not want to get as caught up in child welfare systems as they have been. So, what's typically happened, and there's not an easy answer here, but what is easy is to say women avoid prenatal care entirely when they're afraid that they're going to lose their kids. And when they avoid prenatal care entirely, then we don't know they have syphilis, or we don't know they have HIV, or we don't know they have another, infectious agent that can affect the fetus, and that can affect their own health. So we're trying to do something here with this Health Engagement Hub to sort of break that cycle. So I have some hope for trying to get through that. Okay. I'm sure there's going to be questions about that, and I'm really excited to answer those later. Next slide. Okay, so what we're working on right now, we bought a building. Did I mention it? The terror. Okay, it's fine. It's so Cole's going to come out and help me demo everything, right, Cole? We're hiring an SUDP. We've had some trouble with that as well. There are only a few of them in Walla Walla County. The wait is very long. I told Healthcare Authority I have watched my clients pass away waiting for their SUDP assessment in the past. And I don't say that it's a terrible thing. It's a really terrible thing. So hopefully we can perform those assessments ourselves in less time. And our physician will be our clinical lead, and then we're currently in the process of hiring and making an offer to a non-medical program manager, and they will work together to support all the staff, medical and non-medical staff. We're also going to put a part-time nurse in Clarkston, having a co-located nurse at our SSP, which we've had in Walla Walla and Tri-Cities for a while now, has been a real game changer for a lot of our SSP participants. So I'm excited to see what happens in Clarkston, especially as you all probably know, Idaho rolled back its legalization of harm reduction a little while ago, and shut down a number of SSPs as part of a raid. So we are right on the border with Idaho out there. And then this partnership with Planned Parenthood around reproductive health care. There's a lot going on. We want to try and get some methadone access to our folks. Right now, they're all about an hour away, maybe even more, either from the methadone provider in Kennewick, and then there's one down in Pendleton, Oregon, which is about 45 miles away from us. So even just being able to take people to methadone appointments and replace inconsistent support that they've had will be important for some people for whom buprenorphine has not been enough of a practical therapy. So we're interested in trying some new things out here and then reporting back. My hope is that we can show what is the efficacy of moving to more comprehensive services for people in a low barrier, harm reduction, trauma informed value model. And if we can do it out in Walla Walla, I think there are a lot of other places where we can try and implement a similar approach. Next slide. So we open in the fall, as soon as that contract is signed. Um, we're really looking at, we're not just taking people who are like, I want free primary care. We're really looking at folks who are not currently in care, or they're not our, maybe they're our established MOUD clients, medications for opioid use disorder clients, but um, they're not otherwise engaged in care. This does get a little bit tricky with our physician because she has a no compete agreement with her previous employer. So we're going to have to look and see, is this person seeing a physician? Were they previously seeing her, back at her old facility? Were they seeing any other doctor at that old facility? We have to make an attempt to establish care with them. If they were discharged from a practice at her previous employer, then I think they're free and clear, but their lawyer still needs to tell me if that's okay. So, even if you're operating a low barrier program, you're still in the context of traditional care. And so there are always going to be considerations to think about when rolling out a new or innovative program, because, we're still in the healthcare fabric of the country, and it's got lots of considerations, or, minds. um, The wraparound services, as far as I'm concerned, are still very critical to support. As much as we can support housing assistance needs, housing, everybody will tell you, is a really big deal. If people don't have a safe place to be, they're really demotivated to change, because they're being told constantly, you don't deserve this, you don't deserve this, anything good, right? This is you're a piece of whatever, and this is what you deserve. And it's just really hard to break through that level of like downward pressure on clients. So we really want to be able to see that they have a safe place. And I'm fine with doing handoffs to traditional providers when they're ready, although you have to be, careful about how long that window might take you to get to. Okay, next slide. I think it's just questions. Oh, how will we sustain it? Well, okay, we got this initial contract, and then we're going to be seeking additional contracts afterward, and then we'll be looking for fee-for-service billing as additional revenue, although sometimes that means you have to do takebacks on your contracts, so you have to look at what kind of revenue are you really going to be getting, between fee-for-service and more traditional contracting. I'm always on the lookout for, financing for capacity and facility improvements. And you have to be careful. Does the allocation, or, allocatable money say you can get any kind of equipment unless it's bolted down? Does it say you can get, so this little picture of this 2-room medical clinic, mobile medical clinic, was a big deal, trying to get funding out of CDC for that, because they said, well, the federal government doesn't support vehicles. And I said, well, it's not a vehicle, it's a mobile clinic. And they said, no, Everett, you can't get it. And I said, well, what's the federal definition of vehicle? And then they came back to me 2 weeks later and said, you know what, there is no federal definition of vehicle. And I said, great, I'll get a loan for the vehicle part of the clinic, and you can pay up the other, 3/4, 4/5 for everything else. And so that's how we work that out. So ask me later how that went. Okay, next slide. So I think I saw, how do you deal with community backlash? Sometimes I go out, Samantha, and ask for a champion or a surrogate to make the case for me. So if I am having trouble with someone in a prosecutor's office or someone on a county commission, I ask for someone who's a counterpart in another county to give them a call and make the case for us. Sometimes I will ask to do a workshop. I did that before to the Kennewick City Council and talked about, the data behind things. And you might not win over the people on the elected body, who are most resistant to you, but you might win over some of their colleagues, or you might scare the attorney for that body, and then that's what happened in Kennewick, and then they backed away from real egregious regulations they wanted to enact. You've got to do great data collection, and you're going to hear your staff complain that they don't have the time to do it, but you've got to just keep pushing them to do it and help them figure out how to do time management so that they can really get great data in there. You're welcome, Caleb, because we really have to be able to show that the program works or not. And we just can't show that the money is used well or that we got the outcomes we said we could get unless you really got an eye on capturing your data. So you have to make it easy, simple, reliable, and continue to look at it. And then you've got to like build your reputation of excellence. You've got to do the great work. You've got to show up for people. Like Cole said, you have to be the compassionate leader, not just for your clients, but for your staff and frankly, for your board if you have a board. And I think, you know, you look to get your support from wherever you can. If you have local support, then great, build that up. If you have support from the state or even nationally, then use those to get the investment that your local people won't give you. Okay, next slide. I'm sorry I talked a lot. I said this earlier, you know, if you can do it, you should do it. If it doesn't break anything, it's going to help the people you're trying to serve. Find a way to make it happen. If someone else is doing a service in your area, but there's still a community need, you're not duplicating the service. You should do it too. There's really not an issue there. I hear much too often in philanthropy circles, well, so and so does this. Okay, but if you've got someone coming to your office and they're already in your office in front of you, why are you going to say, sorry, I don't do that because so-and-so clear across town. I know you don't have a car. I know the bus isn't going to pick you up for another 4 or 5 minutes, but you go over there. You just blew all your trust with that person. Don't do that. Find a way to do the thing. And you'll serve everybody better. Next slide. Okay, we don't care about that. That's old anyway. Just saying it has to come from multiple sources. And then that's my younger kid looking really busy. So thank you all.
Thank you, Everett. And folks, if you would please put questions in the question and answer box. Cole and Everett, if you'd please turn your cameras back on, I would appreciate it. Thank you. But again, please put questions in the Q&A. I have a few questions for you guys. But I first want to just mention a couple of things. First, I just want to thank you for your amazing work and partnership. As Everett mentioned, we do have our monthly calls. There's laughter and there's tears. And you can probably tell why, because this is really, really, really hard work and really worth it. And as someone who is based out of Seattle myself, the University of Washington, a lot of the work does often kind of start in Seattle. And in fact, when it comes to some of this low barrier access to buprenorphine and other services, some of that really did start back in 2015 on the planning side. Also colleagues, Shelley Little and Cindy Grandy with these parallel ideas in their communities up and down I-5, and also amazing work even in San Francisco and Boston and other places. But what you're hearing about is this evolution from low barrier buprenorphine at a syringe services program with a nurse care manager model. Then with the first iteration of Medications First, expanding that to 6 sites, including these sites, and adding in the Care Navigator. And I feel like the Care Navigator, you've heard it a lot today about health engagement. And I think this really is all about engagement. And the Care Navigator is literally and figuratively kind of the personification of harm reduction. They're the person with the time and the space and the proclivity and very often the lived experience to sit with, join with, listen, support the folks who are coming in. So that's really important. Version 3 of this was really folding in some work around stimulant use disorder. I'll note to folks that one element of that is mental health coordinator. Another element is some contingency management. We just put out a brief last week, I think it was. Maybe if Allison could track that down and throw it in the chat, would be awesome. And that is around what does contingency management look like in the context of harm reduction programs? At first blush, that may seem antithetical or paradoxical, but there's really nice ways that can come together. And then really this health engagement program, health engagement hub model of care, still foundationally around for serving folks who use substances on a drop-in basis and really trying to flesh out as many of those services as we can. Exactly to Everett's point, the person is sitting right there. Why don't we offer them everything we possibly can right there, whether it's infectious disease testing, family planning services, wound care, mental health care? Let's just do it. They're there and they're often not going to show up or able to show up. in other places. We're also going to be putting out a toolkit very soon around the clinical and social supports for these health engagement programs. There's a lot that we've learned from and with Everett and Cole and the other folks, some of them on this call, Paul Lakoski and other folks around how to do this work in Samantha and in Spokane. So with all of that, this is just really amazing work. And I do want to take a moment maybe to jump back to Samantha's question about how do you deal with backlash. I know from watching you both, it is a process of both and. We're going to do our best to sort of try to head it off and prevent it and engage with folks. And then also when it does happen, unfortunately, have to react to it. But I'm wondering if you could each speak a little bit to what you've done to try to sort of prepare people for your programming before it comes out and what that looks like. So maybe Cole, could you say a little bit about, what you've done? Often when we're reacting, we're also preempting, but some of that work that you've done to be very purposeful.
Yeah, so yeah, it's certainly very challenging. So when it came to the implementation of our, say, syringe exchange program, we were rallying to be involved in Lewis County's opioid response plan and networking there and discussing with individuals, stakeholders in the community, on one hand, to make sure that they were aware of what we were up to, informing them as much as we could, but also being clear that, it's really kind of ironic to go back and think about this right now in light of some of the things have come down around syringe exchange in Lewis County recently, but letting them know that we were going to move forward with this. And so it wasn't a matter of I need your permission, but rather we're moving forward with the syringe exchange, but we want to inform you, to share with you, to bring you on board, to educate you. And initially in those first, 3.5, 4 years, there was a lot of community support overall. And there still is a lot of community support. But now, most recently, as some of you are probably aware of, there's been more pushback amongst a handful of individuals that are in influential positions trying to restrict and or limit some aspects of harm reduction work. And that's based on the 5536 bill and some of the language there. And we don't know. So there's officially in Lewis County now, for the first place in any county in Washington, a syringe exchange ordinance. And it's somewhat restrictive, but not closing by any means down syringe exchange work. It's just restricting some of the supplies that we can hand out. Nonetheless, so education, listening, talking with people, trying to in general, educate the population at large, as well as leadership, is key. But we've also found, again, that doesn't work for everyone. Some people just have a fully jaded attitude and aren't willing to look at meaningful research, peer-reviewed research, evidence-based research. They are wanting to find something that supports their preconceived notions, and are unfortunately misunderstanding, causation, correlation issues. And so they're looking to things like overdose rates going up due to fentanyl and blame harm reduction, as many of you are probably very well aware of some of this rhetoric out there. And it's really, really hard to undo that. It's really hard to challenge people on those things. Folks are really, really stuck just wanting to find something to blame, and oftentimes for more political reasons than actual compassion or wanting anything to overall health experiences for people to improve. But again, it's just really, really hard. And I'll hopefully learn more as time goes on to how to address and deal with some of these things, because we certainly don't have it all figured out. That's for sure.
Yeah. And Everett, also from your perspective, I remember coming out probably 5 or 6 years ago when you were starting to do this work and hosting a community meeting around opioid use disorder treatment within purposely, I believe, healthcare providers and healthcare systems. And I think maybe also talking about sort of why working with those folks, and also what I've seen is the positive enabling force of getting other people to step up once they know that you're there. They're like, oh, well, if we know we can send them somewhere, then maybe we'll initiate care. If you could speak to that a bit, I think that'd be really helpful for folks to hear about.
Yeah. And I want to just contextualize things by saying, fentanyl has an extremely high association with overdose. It's just unlike other things that we had seen previously to its arrival. It has clearly overtaken the space formerly occupied by heroin prior to COVID. And so, we see it more than we were seeing, because that overdose event is the thing everybody can see is happening. As we also go into, a deeper housing crisis, more substance use is out in public. And so, there's a collapsing effect here, an exacerbating effect here between these things. And so regular old garden variety residents in your community are seeing things that they were not seeing a few years ago. And they're really worried because they're clearly outside the bounds of what we think we're going to see in society in a given day. And so I want to acknowledge that, like, fear around that is the normal human response. But we're trying to then provide information and responses and services so that we can, to somewhat degree, mediate that fear response and get everybody back to that place of compassion and, hey, we can do this, we can pitch in and do this. So, I guess I would say, harm reduction works in every single right? So if you are a sphere and there's all these different, directions you can go off in, that's where the harm reduction space is. So I took a physician out to lunch many years ago, and I said, "You're a smart person. I respect you a lot. Why aren't you prescribing buprenorphine with your patients? I know you have these patients, you've got 2,200 people, like one of them has to be addicted to an opioid, and I said, what is it you need? Is it a pony, $10,000? Like, what are your needs?" So what I was doing was, a root cause analysis of why I didn't have physicians prescribing Suboxone in my community. There was one, and they were a VA doctor. So guess what? You can't just go and see them, right? And she said, "Well, I'm worried about people being, unruly in my waiting room." And I'm like, "You would really be worried about them nodding off, like not being unruly." But, so right there, it's telling me something important. It seems hard to get the X waiver, at the time there was still one of those. She gave me a list. I'd need another second person in my practice who could also prescribe so that I can go on vacation. She gave me the whole list. And when we went and said, okay, and we're working with Caleb and UW, this is what this is what my handoff people are going to need. I went to them with, this is what we'll do for you. And if you take someone on a warm handoff from us, and then they start to have trouble again, you think that they're relapsing again, you can call us, and our care navigator will be right back there to try and help support that person and respond. So you can always count on us to be, a support for you, the provider.
Yeah.
That really made a difference. And suddenly we had 4 people signing up and doing the training. And, it was so easy to work with the trainers. But then, of course, nothing is ever settled. And that's the other thing. You can train everybody. You can do your symposium. You can have 300 people, 5,000 people come. You could have a big revival. It's great. I promise you, a year later, you're going to have to tell everybody about it again, because people forget, people misremember, people leave, you have attrition. Somebody knows somebody's daughter's cousin's friend's brother, who overdosed on Suboxone. So they heard, and now nobody wants to prescribe it. And you got to go out there and do all your information planning again. So have as many people in your community willing to do stuff. I had one doctor who was prescribing, and his wife said, "I hate Walla Walla. I took a job at Boeing." Boom, they moved to Seattle. They're gone. I had another doctor say, "I got 2 little kids. I can't take my whole panel anymore. I'm moving into sports medicine." Boom, he's gone.
Yeah.
But what did they both say to me on their way out the door? "My best patients were the ones that you sent to me. My best, most engaged, most careful, most medically adherent patients were the ones Blue Mountain Heart to Heart gave me."
Well, I think where you're speaking to, you have to keep feeding this machine. And
Yep.
part of that is giving the information feedback to folks about the successes you're seeing, because first responders and emergency departments and jails, there's a bias in who they see, and it's not the folks who are generally doing well. So I know you both know this and do this, but it's important to, continue to provide updated information, including how the program's working and the successes. and also the evolution of it as the drug market is unfortunately continuing to change pretty quickly. But thankfully, we're actually at a place with pretty rapid evolution in our treatment medications as well, which is pretty exciting. I want to turn a question from Alexi Orr, who I'm super glad is with us. And Alexi asked, we've been coming across people working within the harm reduction community who have bias concerning safe smoking supplies. So the question is, does this come up in your organizations? And I'll also kind of note a contextual thing that I'm realizing, having done this for so long, like it's always confusing. Like, how are people more afraid of smoking supplies than syringes? That's just confuses me. And then I realize it's actually the fact that they're easier to use and people may be more comfortable using in public and using fentanyl much more often. So to exactly your point, Everett, it's much more in your face and feels like it's impacting their community. So I wonder if you can say more about how your organization is handling issues around safer smoking supplies, and also maybe how you're trying to educate your partners about them.
Yeah. Well, we give out by the piece. And if I look at, I think we gave out something like, and I think Malia is in the audience somewhere. And so if I misstate the number, they will correct me. But by my count, we gave out more than 12,000 pieces. So that would be like a pipe as a piece, bubbler is a piece, a mouthpiece is a piece. But the demand for safer smoking supplies is very increasing and very significant. We have probably seen a downward trend of about 70,000 syringes a year since 2020 in our overall annual count of what we are exchanging. There's a lot out there, that the crack pipe thing is like a big boogeyman, and it's a remnant of the 80s hysteria around crack, and it's still present for us. But if I'm not giving out a safer smoking kit, and people are going to a local gas station and getting who knows what kind of foil, who knows what kind of glass, who knows what chemicals are on there, we at least know we're giving stuff out that's not going to add harm to the experience of them consuming that substance. And that is the same harm reduction basis that we've been giving out syringes on.
Mhm.
The thing that I've always been, questioning is, I know they should only use a syringe one time. I know that the science is out there showing us we don't want them to use it 2, 3, 4, 10 times because of the deformity to the needle itself. But I don't have a lot of good evidence on like how long should you use a glass pipe. Obviously, you want to get it before it breaks, and we've asked people, how long do you use these before you turn them in? And we've got a variety of answers, but there's no great study out there yet. And I would love to see it, University of Washington. But
I will say the study we are doing, as you know, with some of your data as well as Tacoma's, is it really looks like what we're seeing with safer smoking supplies is that there is a very high demand for them. We know from the 2023 Syringe Services Program survey that actually most people are smoking and a smaller proportion are now injecting. And we know that new people will come in and begin to engage in services when smoking supplies are offered. So we do know those things. There's certainly more to learn. Cole, what is your experience looking like?
Yeah, well, so this is super challenging for us because of the recent ordinance that's passed. And so those things are listed as things we cannot distribute currently. And so, of course, we are working to help inform and communicate the necessity and the benefits of safe smoking supplies to our community at large. But it is a really hard one. Much of what Everett just had to say is the same experiences we have here. A lot of stigma, a lot of images that people have in their heads of what a pipe is going to be looking like and what it is, and a lot of fear and hysteria around that. And then of course it connects with this notion the general public is going to try and suggest that to hand out safe smoking supplies doesn't have a public health influence. It doesn't increase overall public health or reduce public health risk because it's not dealing with bloodborne pathogens and the like. So people dismiss that it's actual harm reduction intervention or question it, even among those who are maybe somewhat supportive of harm reduction and syringe exchange. They question this notion. And so for them, it's oftentimes also coupled with the ideas of enabling and or endorsing somebody's substance use. And that's a huge hang up for people. And I think in that, there just needs to be, again, a lot of listening, a lot of hearing people out, a lot of connection to good information, and trying again to undo that. Because as we talk about, oftentimes, if somebody has a substance that they want to use, they're going to use that substance, whether they use it in a safer manner and a less safe manner. And that's the idea that people can't quite connect with. They think somehow if they don't have access to a syringe or to a pipe, they're not going to use that substance. And we know this to be untrue, as Everett also was naming. If somebody's going to the convenience store and picking up some foil that who knows what it's made out of, and they're using that as a mechanism to smoke, there's obvious harm that can come by way of somebody. But more to the point, people are going to do whatever in order to use the substance that they want to use. And so helping our community understand, and helping people that, in general, understand that concept, especially as related to somebody's substance use disorder. And then more in maybe of equal importance in the big picture is this point of contact and connection. As we know, people are way more likely to pursue other in healthcare interventions if they can gain access to them, and treatment services and whatnot if they're accessing harm reduction programs, syringe exchanges, safe smoking supplies. And so ultimately these things work favorably toward overall health of community and well-being of a community. It's just a matter of sitting down with people long enough to hear them out, to then share meaningful and real evidence-based information with them. So, but it's challenge. Big time.
And I do want to note something that both you and Everett mentioned, which is listening long enough to people to hear them out. And it's easy for us, and I certainly count myself within this, to say they're wrong, the evidence is clear, blah, 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 blah. But I think, as we all know, the only way to possibly move a person towards change is to understand their perspective. That's it. There's no other way to do it. And that means, one, restraining yourself and really listening to what they're saying and understanding why they're saying that, because it's coming from something that is true for them, and understanding that is essential. And that means having dialogue, which can feel really hard with someone who may be not very nice to you in public or vitriolic. That it's so I I commend you both. I learned from you both in that, because it's incredibly hard work. And it doesn't always work. So
right.
I just note that that is one of the hardest things I think in our jobs, is doing that, but it's also can be really.
Yeah, right. Well, we certainly want to engage people, and if we're really invested in a harm reduction, approach and methodology, we have to look at, this very fast changing. I mean, nitazines or whatever are gonna hit us at some point, and we're gonna be tweaking our services, tweaking, the great word, all over again, to make sure we're really meeting the need. We bottomed out in transactions when we were sticking with just syringes, and bringing in safer smoking kits really brought people back in who had stopped coming to us, and brought in a whole new kind of cohort of folks who were smoking. Did we have some bumps with, kind of explaining our expectations for behavior when people were coming in to our office for the first time? Sure. But, I think we probably had that back in 1998 too. So it's just always about open communication and,
I do want to just give briefly, since we're having this meeting with all these folks, some context for what Cole was just saying, and is that the Washington State Legislature last year did paradoxical things adjacent to each other in law. One of which was expand access to harm reduction services and the right to harm reduction services, and explicitly including safer smoking supplies and drug checking supplies, among other things, and then allow local municipalities to preempt that, which is what has happened in Lewis County. So if people are curious what Cole's speaking to, it's that. And I believe you are unfortunately the first county to have done that. So something for people to be very much aware of within state law. And again, that's not for any lack of education and preempting that Cole was trying to do. They did a ton of that. It's just one of these, the forces were pervasive on that front.
And we're not done with it yet, right? Like
I'm
it's
sure
passed, but
I don't
it's
think you're
getting
done. That would stun me if you were rolling over and done on that one. Involved
right.
creative, as Everett did, using federal dollars to not buy a vehicle. So I'm sure that will continue to be creative. And I'll just note there's been a couple comments in here around Everett being one of them, but also around safer smoking supplies. That this isn't just like, oh, let's just make it more convenient to use drugs. It actually is around communicable disease risk and reducing that risk, both through the sharing of those supplies, as well as also wounds and injuries that can happen from burns and smoking that can create a portal for infection. So it is a real thing. It's it's not made up. So we have a couple more minutes. I think, there's a lot of things that we could talk about, but the one I kind of want to focus in on just for a moment, and I think particularly since, as Katie noted, we had almost a third of folks who identify as having living experience, is just sort of the briefly, and it's not easy to do briefly, but I know you both have done amazing work on this in terms of hiring people with lived experience of substance use in a range of roles, not just in the peer and care navigator role, but also in some clinical roles as well. So maybe if you could both speak briefly about sort of why, how, and the value of that. That's too much for 3 minutes each, but try.
Go first, Cole. You can do it.
Okay. So 3 minutes. Wow. Yeah. Okay. I'll get started. So it is hugely important, obviously, right? Because people bring a set of experiences that are transformative to the care model and are oftentimes there can be challenges in the other direction too, for what it's worth, with some having lived experience, but they bring this set of experiences, generally speaking, that are constantly attuned to experiences that people might even have when we're trying really hard, where there might be a touch of stigma or something going on within one of our people within the care team. And they're like, hey, Cole, there was this thing that happened. We need to address this, right? And so they're just like, I don't know, when it comes from an organizational standpoint, they're like the radar for stigma, among other things, and they hear it and they give us feedback, and we can address issues or make changes as necessary. And then, having lived experience staff that are present, that are have experienced oftentimes themselves the stigma, the rejection, and passionately pursue clients, caring for them, loving them where they are, offering unconditional positive regard, and being able to see people differently and help those individuals see themselves differently. It can be really challenging when it comes to offering employment to a range of people, but it's beautiful. I believe strongly we need one another. MDs that have not any lived experience, that are open to these kinds of care models, they learn so much from our lived experience staff, and vice versa, right? We all need one another. That diversity is incredible, is beautiful. And there's such richness in the workplace because of having that diversity. Hopefully that was 3. That was 2.
Great. That was great. That was good modeling for Everett.
Great. Oh, great. I'll second everything Cole just said and say, part of establishing trust, part of understanding who you're serving, part of reducing trauma is having your staff reflect the people that are your main clients. We also have had people on staff living with HIV and or AIDS because of that same reason. It's really important to us to have folks with lived experience on the board at all levels of our organization, and not just in one particular role. I just had a kind of a little bit of a fight with my county because they're rerunning all these background checks for people who work at the jail. And so they told two of my case managers last week, oh, you can't come in and see people because you failed the background check because you've had something in the last 7 years or something. And I was like, well, then you're going to have to like, send out these other 3 people who work there at the jail. Like, what are you doing? Oh, no, we didn't. That was a clerical error. We can overrule anything we want to overrule and blah, blah, blah. And I was like, you're pissing me off. But you're also my collaboration partner. So, we worked it out. But I think, you know, there's a lot that people with lived experience bring to the work. And I also want to try and be extra supportive of staff with lived experience because vicarious trauma might hit them differently than it does some people with other kinds of lived experience that aren't, what the client's presenting them with that day. Um, some of us, have had conversations about having our own support group meeting, be it an NA meeting or, one of something that's not 12-step based, but is still a recovery group, just for our own providers and opening it up to other providers because it's really hard when you're trying to go to your NA meeting and there's your client in the same meeting with you. So there have been some things that we tried to like wrap our heads around. We moved to 160 hours of paid time off a year because we think that the work is that demanding that we need a full month of paid leave. And then of course there's 12 holidays in there. So, when you think about policies and support strategies for staff with lived experience, you wind up raising all boats for all of your staff. And so it's been really good for us as an organization to have this many people on staff with lived experience around substance use because it's helped us all, I think about, how can we balance and do this work in a sustainable way going forward because it is so challenging.
Great, thank you. We're at 10:15. We're gonna take a 10-minute break and come back at 10:25. I also want to note that I see Tracy's challenging and difficult question in the chat. I will respond to it, and I encourage other people to respond, with any ideas that they have as well. So we will stop there. I just want to thank Cole and Everett as well for today and for everything. Incredibly appreciative of your great work and insights. Thank you for sharing that with this group. So we'll take a 10-minute break. Go take care of yourself, and we'll see you all in just a few minutes.